Thank you. Thank you, Tana, and thank you, Johanna. This is a much overdue network because mental health as an object of research does not belong to any one discipline. And there is a lot of work to be done through such interdisciplinary conversation. How well can you hear me in the back? Yeah, thank you. I'll do my best. So we've been asked to be specific about our methods because it is a interdisciplinary network, but with philosophers of science and methods are hard to specify, honestly. It's famously difficult. I think the easiest thing to introduce what we do is we do exactly the sort of thing that scientists do in their quiet moments of reflection, but we just do it more systematically and at length. So a lot of what we're going to present here today is informed by extremely thorough research into theoretical and methodological approaches to mental health nowadays, and quite intimate knowledge, participatory knowledge in case of Sebastian, of the process of measurement and application of this knowledge, especially with young people. So that's as much as I can say about our methods. And our question today is why mental health is hard to measure, and we have basically three answers for you. The first is because it requires value judgments that are hard to justify for all purposes and for all contexts. When philosophers talk about value judgments, what they mean are claims that you wouldn't be able to justify purely on the basis of empirical evidence or logic, but claims that have something to do with what you wish were the case, what you think is good to be the case, what you think is right to be the case. So value judgments are usually to do with what is good for us and what is right for us and how we should treat each other as human beings. So which brings us to the second reason. The reason why these value judgments are especially difficult to make in the case of mental health is because they're not just any value judgments. They're not just you say potato, I say potato. They're judgments about how we ought to live and how we ought to organize our lives. So that's a pretty big deal. And that's why it's even harder to justify them once and for all. Which brings us to the third reason, because the third reason is all about measurement. The point of measurement, the reason why measurement is so central to science and evidence-based policy is because it enables comparability of outcomes across very different spaces. There wouldn't be any point to measure anything for all x if that x was not comparable to another instance of that x. And to ensure this comparability, you have to sometimes divorce that thing from its original context, make it slightly more separate from where it came from, just so that it can be comparable to another instance of it. That's the point of objectivity and standardization. There wouldn't be measurement without it. But you could imagine how hard it is to obtain these two values of standardization and objectivity when you're measuring something that depends on not just any value judgment, but value judgment about how you ought to live. So I will cover briefly those two reasons and hand over to Sebastian for the really big one, the third one, which concerns probably most the interests of people here, since you're probably researchers of mental health. When I first started thinking about definitions of mental health, I saw that there are these two extremes in the literature. One is a very, very minimalist definition of mental health as just absence of disease, in this case, psychiatric disease. So you define disease by reference to DSM on the International Classification of Disease, and you say mental health is the absence of that, or the extent of the absence of that. This is an extremely common definition in science, But the only person that comes out and defends it explicitly is a philosopher called Christopher Boers in 1970s. And since then, he's been defending it. I'll tell you more about it. And this is juxtaposed to a very, very demanding definition from WHO, the World Health Organization. At least that's where it comes out explicitly. There are also other people who defend it more theoretically. So rather than just absence of psychiatrically diagnosable conditions, mental health for World Health Organization is a state of well-being in which every individual realizes his or her potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So this is from 1948. That's when they came up with. They came up with a definition. Well, actually, it was definition of health that was in 1948, and then they extended to mental health. So negative, positive, two poles, right? They are, in my view, both very problematic. So health as absence of disease is, you first need a definition of disease, and Christopher Boers famously provides that. A disease is any type of internal state of the organism which interferes with performance, and defined in evolutionary terms, and not specific in nature of the species, i.e. either atypical of the species or if typical mainly due to environmental causes. So there are lots and lots of fiddly discussions about exactly how this definition works, whether it's a good one, how you could adjust it. But the important thing for us is that in order to extend this definition to mental health, you need a conception of mental functions, right? Just like you would have a conception of functions for, say, heart, right? The function of heart is to pump blood. You need a conception of function of whatever faculties you have, right? And that's been very, very difficult. Boers himself in 1970s proposes like a psychoanalytic conception of those mental functions. And I don't know if anyone has tried that any further. But it is also the case that negative definition, which Boers is at least trying to articulate here, is the most common in research. Most commonly in research, people just measure the prevalence of mental illness, and to the extent that there is not a lot of it, say this is health. So lots of reasons why you shouldn't go with the negative conception, I think. Boers really thought about it as a way of avoiding values, but you don't avoid values because any definition of mental illness is, involves value judgments, as many people have shown. So you kind of only avoid certain value judgments. But the good thing is you avoid a conception of an ideal human being. And he was, I respect Boers for that. He really, really wanted to say that we don't want to have a positive conception of health because that's a recipe for a good human. And that's not a job of medical research to provide that. What's wrong with the most ambitious definition? There are plenty of them. Well, what's wrong with them is that they are too ambitious. Who doesn't realize their full potential, who doesn't work productively, who doesn't contribute to their community. I think that's most of us. And it is, there are, you might think it's good to set out ideals, but sometimes you don't want to actually, because that just medicalizes unhappy people and makes it seem abnormal. This is exactly also the problem of identifying mental health with subjective well-being. Which also sometimes happens and is actually a big mistake. We can talk about that if you're interested. I think a lot of charities that talk about we are in the business of well-being and we are going to we're in the business of mental health and we're going to use knowledge about well-being to give you mental health, make this mistake too, right, of conflation. Is there a right theory in the middle? I happen to think there is. I've written about it, but that's really not, I think it is possible to offer a positive conception of mental health, but not quite as ambitious as WHO's. But that's not, we can talk about that at the end if you want to. Perhaps the final theory of mental health is not even necessary to get job done for measurement. You could measure just the indicators of mental health and say, I don't know what mental health is, all things considered, but I have some really good indicators of it. A lot of science gets on in that way. There is no shame in it. And absence of mental illness could be such an indicator. But even then, you need to decide which illness, what counts as absence of it, which degree of precision. And even then, you've got your work cut out for you, because measurement itself introduces all sorts of further value judgments. So at this point, I hand over to Sebastian.
Well, thanks, Anna, for that great intro and presentation, and thanks to Tanae and Joanna for having me. So again, I'm Sebastian, and I'm a visiting research fellow, postdoctoral fellow at the Department of History and Philosophy of Science. And so here's just like a breakdown of this part of the presentation. First, I'll go briefly over methodology again, then give some background on what I'm talking about, and then go over some challenges to this puzzle that I'll address, and then finish off with some ways forward. But so here is sort of a few words on methodology. As Anna mentioned, it's kind of hard to pin down exactly what philosophers do, but we develop arguments is the baseline of that. And we do conceptual analysis based on reviews of the literature and knowledge of the literature. And as philosophers of science, that also means just being aware of the state of the art of our own science that we're interested in. In addition, I do something a little bit different. It's called philosophy of science in practice, which is kind of this catch-all term for a variety of different practices. But in my case, it has meant, for my thesis, close collaborations with scientists in a couple of different projects. And so for this project, it was a collaboration between Dr. Skye Barbic, who's the head scientist of this organization called Foundry, which is an integrated youth service in British Columbia, Canada. So those are where all the centers are in British Columbia. It's pretty large. Like last year, they saw some 17,000 youth. And then the other collaborator was my previous supervisor around Tal. And so I was one of their research assistants, but it turned out to be my entire thesis, or very large chunks of it. Of course, there's different ways of measuring mental health that we might talk about, but today we're focusing on health questionnaires. So health questionnaires are psychometric instruments, and they're a key tool for what's promoted as measurement-based care in mental health. Psychometrics is the science of measuring mental traits, abilities, and attitudes, and it underlies the design of a lot of all these patient-reported outcome measures, which are the main instruments used in measurement-based care. And so just briefly, measurement-based care refers to sort of the use of these tools at different time points to track changes over time in a patient on an intervention. So here is the PHQ-9. You may know it. It's the Patient Health Questionnaire. It's a widespread measure of depression, and its 9 items are modeled from the DSM criteria for major depressive episodes, and it's validated against health surveys and interviews. It's a helpful example because it also shows you the authority of the DSM in shaping these constructs. And so just briefly, scores range from 0 to 27, and say 10 to 14 indicates something like moderate depression. It was originally developed as a diagnostic aid, but now it's broadly used for screening and for lots of different purposes in lots of different populations. So I need to make sure I'm switching on both computers, that's all. So very generally, the point of a measurement procedure, like putting down answers to a questionnaire and tallying up a score, is to achieve a measurement outcome. And for our purposes in our discussion today, a measurement outcome is the interpretation of a state of the instrument, in our case, the score, leading to a decision. And so we could talk about research, but today I'm focusing a little bit more on health services and the clinical case. So in this, for my purposes, these interpretations and decisions in mental health happen clinically between clients and service providers, and they happen systemically across institutions and organizations. So the next two slides are really busy, but they're meant to kind of give you a sort of bird's eye view of how this works out in practice. So we, as part of the project and the collaboration, we prepared a sort of guidebook for clinicians on how to do measurement-based care more critically. And we kind of developed this idea of a measurement map. So this kind of shows you like there you go. I got a whole laser pointer just for this. This kind of shows you the little different purposes you might have in measurement. So we divided pre-screening and screening, but really, you want to be screening people, then you want to be tracking progress, and then this kind of tells you the modes of administration, the instrument, and where the data is going, and who's looking and what's the decision. And then this is the young person named Sam, and this is their health journey. This is a nonlinear health journey where they're going to visit more than once, maybe visits 2 to 14, which is where you're doing your progress tracking. And then maybe a year later, they're not going to feel so well after discharge and return. But so just broadly, there are at least two reasons to use measurement in a clinical setting. One is to screen for a particular property and to track progress in an intervention. And so Sam can walk in and be initially screened at the front desk with a more general measure for distress, say like the K10, but then maybe a particular need is identified and Sam is directed to a specific service provider like a counselor, and there the counselor may use a different patient-reported outcome measure like the GAD-7, I think, for something like anxiety. And then, subsequently, Sam does other visits, and the same PROM will be applied, and then differences in the score are supposed to be indicative of changes and of sort of the efficacy of the intervention. But so let me complicate this a little bit further, because of course, what we want from the clinical purposes of measurement is to know what's going on with Sam and whether what we're doing with Sam is working. But we also want something bigger from measurement, and that's what Anna was alluding to. We want to be able to aggregate the data from all the instruments from the different time points of a tool administration and make inferences about whether the delivery system is working as a whole and whether it may be improved. So here on the orangey side, you have the representation of all the data being collected and aggregated either through electronic medical records or reports, and then being fed to other agents or other decision makers. And then, that could be politicians at this point, policymakers, funding agencies. In the case of British Columbia, it could be indigenous leaders as well. And then this leads to different interpretations of the data at that point at a systemic level. But so notice how much of it all depends on Sam or someone like Sam. They're the ones interpreting different questions for themselves, and they're the ones arriving at a score to review and make sense of with their clinician. So to achieve high quality measurement outcomes, we need to be confident that Sam understands the questions the way that they are intended, and that the score means for Sam, what the score means for Sam is actually useful and captures the relevant aspect of what we're trying to get at with the measure. If we can't be confident about that regarding Sam or others like Sam, then it's going to be really hard to even begin to use measurement in a broader sense systemically. But so let me talk about three categories of what might get in the way of good measurement outcomes for Sam. The first is just straightforward misunderstandings of questions, so epistemic issues. The second is unintended ethical consequences from the use of measures. And the third is special, is the interaction of the first two categories because of the nature of the thing that we're trying to measure, which is mental health. So in terms of epistemic challenges, for example, people may just misunderstand the purpose of a question and give an answer that isn't relevant to the point of the question. So I really like these examples. They're from Leah McClymonds' work on health questionnaires. The first one, to the statement, I find it hard to reach for things. One respondent answers, well, I do find it hard to reach for things because I'm short. However, McClymonds notes, well, the question is not being posed because of the person's height, it's being posed because of their health. Or in a different example to the statement, worry is keeping me awake at night. The respondent replies, well, yes, but it's only stupid things. I lie awake thinking, but that's just because I'm being stupid. So more simply though, the PHQ-9 asked respondents if they've been having trouble reading the newspaper in the last couple of weeks. But of course, like in an integrated youth service setting, that's not going to be fit for purpose, just on an epistemic level. So just at a basic level, one challenge is that it's not always clear how people will understand the questions if they'll understand them as they're intended, or they may contextualize them differently, or the questions may not be relevant to them. Measurement also raises ethical challenges. So suppose you're a young person who's trekked for 2 hours to a youth center. It's winter in the Canadian Rockies. You're upset and in distress. You make it to the center. You step up to the reception, and they just hand you a screening questionnaire and tell you to come back when it's filled out. It's the PHQ-9. You fill it out, you get a 20, but now you're sort of like a 20 of depression, and you don't know what that means or how that helps you. So measurement and the experience of being measured affects, and we think in our project, we kind of arrived at the idea that it's actually intervening on the young person. So for example, the K10 is a widespread measure of distress, and it asks people if they've been feeling hopeless. Well, if the person hadn't been feeling specifically hopeless before, maybe now they might be wondering if they do. And so then maybe that's just not one of the things that you want to come out of the measurement interaction. So the point is, a good measurement practice and a good measurement interaction isn't about extracting information from the young person in our case, but it's about having an interpretation and a decision that will have the intended therapeutic effects, or at least guide them in the right direction in the health system. So it can point them in the right direction in terms of a screener, but done wrong, it can have the unintended effect of contributing to reification or stigma. So just to go through some of these ethical challenges, I've already alluded to stigma and reification, but it's good to think of measurement as a kind of labeling that can deeply affect how people feel about themselves and how others treat them. And then, of course, if you layer over that the authority of numbers and of measurement itself as a rigorous objective practice, that can have a different way of conceptualizing even what's going on with you subjectively, like in how you conceptualize yourself. Another big concern that came up for us was data access and ownership. So in Canada's context, again, Indigenous groups are are rightly mistrustful of outside agencies collecting data and using data from them. So then there's a lot of frameworks that have to be used just in terms of data governance. Then another big umbrella concern is, of course, inclusivity. So different dimensions of inclusion include gender, sexual orientation, background, and that includes wondering about the language of the measures, but also whether it was developed with the relevant demographics. But then in the case of concepts like mental health, so those are some of epistemic and ethical challenges. But in the context of mental health, those two categories sort of run together, again, because there's value judgments that are just sort of inherent in the whole process. So that's because essentially empirical evidence interacts to shape how concepts are operationalized, how the questionnaires that measure those concepts are designed, and how they're interpreted in new contexts. So these are just a few simple examples. This is an example of the SF-36, a very common measure of general function. So this came up in the case of another collaboration, not for youth mental health, but in terms of function with older adults and active living. And so here respondents are asked, during the past 4 weeks, how has your physical health and emotional health problems, how have they interfered with your social activities? And so, there appears to be already an implication that the health of the respondent may not be very good in the first place. And it's an implication which those older adults resented. And actually, in fact, was a motivation for developing a different measure, which is itself its own value-laden position about what they want to measure. Here's a nice example of how epistemic and value issues are intertwined. So this is from a study by Truigens et al. On the phenomenology of responding to mental health questionnaires. So from the symptom checklist 90, item 27 asks the respondent to rate, I'm too generous towards others. And so the respondent ponders, I won't read the whole quote, but they wonder, well, what do you mean by generous? Do you mean materialistically? In which case, I am kind of egoistic, I guess they mean selfish. Or do you mean about letting people borrow things from me? Because in that case, I'm a bit too generous. And so the respondent actually writes down options for materially and time and services into the questionnaire, I guess it was pen and paper, and then scores each of them differently. So in this case, there's just confusion here about the frame of reference for the question, but there's also a question about what is meant by generosity as a value that the respondent then needs to work out for themselves in that moment. And then finally, the role of values and evidence must also be balanced at the systemic level. So as an example, it may be important from a data gathering perspective to obtain as much demographic information as possible at the point of first contact to build thorough profiles of the kind of client that are using a certain service. Say when they visit the integrated use service like Sam was out in the Canadian Rockies. But that might actually run in counter the immediacy of the distress that they're feeling in that moment. So if the goal is to help this young person, then burdening them with further questions is going to be something you need to trade off. So you have to decide, how much questioning is enough questioning. And that is a value-sensitive question that has real implications for the kinds of information that the system then gets to use later on to help the public at large. So those are the sort of more specific examples, but more generally, in our collaboration with the integrated use service, we identified 3 main gaps. First, there's a disconnect between psychometric literature and clinical practice in mental health. In psychometrics, there's an emphasis on statistical traits like validity and reliability rather than on clinical utility. There are multiple measures for the same construct, but there's not a lot of guidance for how to choose among them. Many measures were not developed for service delivery contexts, but are used to be used in national surveys, for instance, like the K10. 2, there's a tension between the aims of data collection and the value of patient-centered care, which was really important for them in that context. So, for example, clinicians at many levels often viewed the idea of measurement as just sort of like this administrative burden that they have to undertake instead of engaging with genuine care with their patients. And then finally, there is no systematic guide for the ethics of mental health care measurement in a clinical context, period. And in general, there's actually just very little work, or only some work, on the ethics of measurement in general. So one important lesson is the need to make sure that different elements of the practice of measurement are aligned with the values of the stakeholders involved, from the design of new measures that involves the relevant demographics to elicit what really matters to client groups, both in terms of epistemic relevance and their values, and then to the use of quote-unquote valid measures in a new context, which can mean having procedures to ensure that the tools that are selected also align with the values and needs of those in the new context. So work in other areas of measurement can be very helpful here. So Alexandrova, Anna, and collaborator Mark Fabian developed and tested a method for co-production for measures of well-being. And so here they define co-production as an arrangement for sharing power and responsibility in the process of defining thick concepts like mental health and developing their measures. And this arrangement requires first recognizing different types of expertise that each group of stakeholders has about the concepts and their measurement. And second, ensuring that the final product meets, to the extent that is possible, the demands stemming from each of these expertise. Thank you. That's the definition of co-production, which I just read out. On to the next slide. So then they focus on diverse experts in measurement design, such as lived experience experts, scholars, researchers, or policymakers. And so, for example, diverse experts with lived experience are key to help figure out how to operationalize these concepts in the first place. In mental health, a key challenge is that there's a lot of work in co-production in terms of delivery of services and even the space in which the service is going to be delivered. For some reason, it hasn't trickled down to like the idea of actually co-producing measures. So everyone's still using the PHQ-9, but they're like really obsessed about co-producing like the space where the youth are going to be receiving care. And both are important, is the point. And then that's measure design, but what about once the measure is out in the world to be used? Well, in the philosophy of measurement, coordination is the process by which theories and empirical procedures are brought together to achieve interpretable measurement results. And so in psychometrics, this is usually achieved through validation. And so validation generally just gathers evidence about what a questionnaire measures, whether a questionnaire measures what it purports to measure. But the rule of values shows us that this is never a one and done kind of thing. Instead, we need to think about validation as a process that's ongoing. And so it implies that the interpretation of mental health measurement must remain dynamic rather than become comfortably but rigidly standardized. And so just to finish on this, if you're going to be using a measure that hasn't been co-produced, for instance, then you can still introduce procedures at the time of use that will collaboratively integrate the values of stakeholders into how the measure is being used in your own context. So in a paper last year with Iran and with Sky, we introduced the idea of ethical iterations that are sort of a schematized way of doing this. So it involves reflecting on the values that guide something like the design of the PHQ-9 and its conception of depression and whether that aligns with your own practice goals. Then it involves collecting evidence about what the consequences of using the PHQ-9 for a specific purpose might be, like in screening, for instance. And then asking, what do we want about this instance of measurement for the benefit of the client? And is measurement even the right thing to do at this point in care? It also involves engaging clients and their communities to then ask them what their values are, of course, and providing service and collecting evidence about what matters to them. And then trying to compare, revise, and develop a set of values based on the organization's values and those of clients and their communities, as well as on general ethical principles or frameworks. And then finally, in light of these values, deciding whether a construct like depression is the right target, or whether the PHQ-9 is the right tool, or whether if we must use it, somehow there are sort of protocols that can be developed, so like contextualizing the use and make sure that that young person doesn't walk away thinking they have a 20 of depression, but it's actually just a screening instrument at that time and really means nothing except for directing you to a counselor or something like that. So I think we're out of time. So I'll just stop there. Thank you very much. And I guess we look forward to your questions.